And actually, this is a very nice follow-up to this this talk, as I'll be speaking about infectious uveitis again, sharing with you clinical pearls for diagnosis and treatment. So we'll quickly go along this talk, and as we go along, we'll see some epidemiology of infectious disease and review some presentation. I'll share with you some cases in order to refine your diagnostic and treatment skills. So of course, uveitis is a challenging because it presents in so various way, and there's so many different causes for it. But hopefully with these pearls, you'll feel better equipped. So the first pearl is to do a complete eye exam and not to jump over the patient, but actually look at him and ask questions prior to going on to slit lamp examination and so on. To rely on your anatomical classification. This is not only for students, but it actually can guide you toward the correct diagnosis. For example, in anterior uveitis, we know idiopathic is common, HLA-B27 a frequent association, but in terms of infectious disease, you need to think of group herpes and of syphilis. For intermediate uveitis, it's the rarest kind, most commonly in young patients. So if you have intermediate uveitis in an elderly patient, you need to think of intraocular lymphoma. And as for infectious causes, always include syphilis in your differential diagnosis. For posterior uveitis, toxoplasmosis is the most frequent. In endemic country, think of TB, VKH in Asia, and again, always syphilis. And for pan-uveitis, your usual suspects for infectious causes, toxo, herpes group, and syphilis. Look for clues, know what you're looking for, do corneal aesthesia, gonioscopy, look at the iris looking for atrophy, and central location of KPs linked with hypertensive uveitis and sectorial atrophy should make you think of herpes. This is the oral triangle with granulomatous mutton fat KPs, and this is commonly found in sarcoidosis as well as in infectious uveitis such as toxoplasmosis, syphilis, TB, herpes. But always remember that granulomatous disease might start as non-granulomatous. We already discussed that high IOP should make you think of herpes, but also toxoplasmosis might give hypertensive uveitis. And always dilate both eyes. And with dilating the eye, you'll find not anterior uveitis, but suddenly you have intermediate, posterior, or panuveitis. If you see chorioretinal lesion, snowbanking, snowballs. So if you still feel overwhelmed, go back to your patient, ask questions, go back to the past history, the history of presentation, the initial presentation, review of symptoms, and ask for trauma, food, surgery, medication. Beware of endophthalmitis if you have had prior eye surgery or in a case of trauma. Immunosuppressed, look at the med list, and always ask questions for travel, insect bites, looking for zoonosis in our ever interconnected world. Always rule out infectious causes. And we do know syphilis is back. You know your usual suspects, the toxoplasmosis, the viral diseases, but there's a vast array of potential pathogens emerging, and we'll go over some of the emerging infections, which are divided in 4 groups. So first, previously undetected or unknown agents, such as the COVID SARS-CoV-2 virus, which So I was just about to give you the 5th pearl to do a tailored workup. And what does that mean? Certainly, there's a lot of investigation, but I would argue that the minimum workup for anything in uveitis would be syphilis, but you could also consider ruling out, of course, TB and sarcoidosis. The 6th pearl is to use caution with steroids. Especially if you suspect infectious disease, and this is extensive toxoplasmosis, iatrogenic periocular multiple orbital 4 steroid injection, and it was very difficult to control. The seventh pearl, be prepared to change course. Of course, these common infectious uveitis may have atypical presentation. You know, they're your usual suspects, but sometimes it's very difficult to distinguish one from the other. You can rely on some clues, such as a chorioretinal scar near a new area of active lesion, and also response to antitoxoplasmosis treatment. But sometimes you have no such clue, no such scar, and it can be very difficult to distinguish ARN from toxoplasmosis. So do go ahead and perform an AC tap or diagnostic vitrectomy when in doubt. Always beware of the immunocompromised. It's usually infectious. And this is a CMV retinitis in an AIDS patient. You have your typical white necrosis with hemorrhages. This is the granular form in an immunosuppressed patient. And this is the frosted branch gingivitis, again, in an AIDS patient. This is posterior outer retinal necrosis due to VZV, also in an AIDS patient. Again, diffuse toxoplasmosis, but this in a renal transplant patient. Be humble and know when to refer. It's better to confess ignorance than have dire consequences in your patient. And again, it can be very challenging to distinguish one cause from the other. Common saying is, if it walks like a duck, quacks like a duck, it must be a duck. Or if you hear hoofbeats, think of horses, not zebra, but zebra do occur. As in this patient who was initially misdiagnosed as ARN, had a recent zoster, PPD, quantiferon, chest X-ray were all negative. And fortunately, we could identify during a diagnostic vitrectomy Mycobacterium, which was later labeled as Mycobacterium bovis. And he had actually miliary tuberculosis due to M. bovis. Fortunately, this is very rare. It's often a very poor outcome due to delay in treatment. Ocular TB is always very challenging. It requires a high degree of clinical suspicion. And this is another zebra, a young lady presenting on Christmas Eve with a chorioretinal lesion, misdiagnosed initially with toxoplasmosis, with poor response to treatment, which was antitoxoplasmosis med combined with oral steroids, and was found to have candida not only in the eye, but also in the brain, and responded very well to antifungal treatment. And this was due to a CAR9 genetic deficiency. Do not forget the masquerades. We just had a great talk by Dr. Biswas, and especially in the elderly, this was the case of intraocular lymphoma masquerading as ARN. So in conclusion, some take-home lessons. We've seen emerging and re-emerging infections in our global world, ocular manifestations of various infectious disease, and certainly, as we've learned today, history and examination, your clinical skills are key. So I hope that you feel better equipped with all those wonderful talks we had to care for your uveitic patients. So thank you very much.